Hi, my name is Lindsey George. I am an assistant professor at the University of Pennsylvania and an attending physician at the Children's Hospital of Philadelphia in the Division of Hematology. It's an honor to present some information that I hope will expand a bit the knowledge base that I think is important for providing patient education and counseling, as well as monitoring of patients following AAV gene therapy for hemophilia. I'll spend the next approximate 20-25 minutes overviewing is how I go about informing the consent in the context of information that's known relative to available data, and then of course outlining what we don't know and what remain outstanding questions. And it will be broken down as a brief explanation of the use of recombinant adeno-associated or AAV vectors for gene therapy for hemophilia, and then an overview of the known and theoretical risks and supporting data around the use of AAV and the various transgenes, either factor 9 or factor 8. And then, of course, a little bit about what information is already available on preliminary efficacy, which will be framed really in the context of what we know, and then what remain outstanding questions, and then how we are currently going about monitoring patients, which I anticipate will carry forward in the future. So first, a little bit about recombinant adeno-associated or AAV vectors. AAV vectors are engineered from naturally occurring non-enveloped virus derived from the parvovirus family. From a safety standpoint, naturally occurring AAV is not known to be pathogenic and is replication defective, and is generally predominantly non-integrating, which we'll come to later when thinking about safety concerns related to genotoxicity and AAV. And then from an efficacy standpoint, AAV permits intravenous administration for hepatocyte expression of factor 8 or factor 9 following gene transfer. And of course, the culmination of studying AAV for gene therapy is the ultimate goal to provide safe, predictable, and durable factor 8 or factor 9 expression that's adequate to either markedly reduce or prevent bleeding events. So how does AAV gene therapy work? So the vector is intravenously administered with the goal of targeting hepatocyte expression of either factor 8 or factor 9. The capsid tropism is largely responsible for the capacity to transduce hepatocytes. And again, the transgene, either factor 8 or factor 9, is maintained predominantly episomally. And then elements of this episomal transgene are what ultimately drive protein synthesis of either factor 8 or factor 9. And the elements of the expression cassette, including the promoter, regulatory elements, and the transgene itself, are ultimately responsible for synthesis of the factor 8 or factor 9 protein. What do we know about vector-related risks? So first, we'll talk a little bit about what's known about the immune response to AAV. So in terms of a humoral immune response, we know that you can have either pre-existing or developed neutralizing antibodies. So the relevance of these neutralizing antibodies is that if they are present, they will, in high titers, the available information suggests that they would preclude efficacy. So these neutralizing antibodies present in this circulation would prevent effective transduction to the target organ, in our case, the liver. We know that the actual seroprevalence of pre-existing neutralizing antibodies is quite variably reported, and the variation is likely due to various assay methods that are employed that at this point are not yet standardized. And then we also know that universally patients, after they receive systemic AAV vectors, develop high titer neutralizing antibodies, that now increasing evidence suggests that these neutralizing antibodies are multi-serotype cross-reactive. So in other words, are not only to the serotype of the vector infused, but cross-react with other AAV serotypes. And this is outlined in this chart here. These are data from the first patients to receive a systemic AAV vector. You can see this is a small cohort, only 3 patients. You can see they were followed for a number of years following vector infusion. The infused serotype was AAV2. You could see they all maintained high titer neutralizing antibodies for the duration of follow-up, but also had neutralizing antibodies to all other tested serotypes. And this is consistent with what we know about humans after wild-type AAV environmental exposure, as well as from non-human primate and other studies. So the importance of these neutralizing antibodies is that because all patients develop high titer neutralizing antibodies that again appear to be multi-serotype cross-reactive, that these neutralizing antibodies likely preclude repeat vector administration. So What this effectively means, the current state of science anyways, is that patients can only receive one lifetime systemic AAV vector infusion, which is both the goal, but also appears to be compulsory. So from the standpoint of the physician, that means to choose very wisely what vector you choose to recommend for a patient. And then the second aspect of what's known about the immune response to AAV has to do with the cellular immune response. So this is the so-called capsid immune response. So the working hypothesis is that you have vector particles will transduce your hepatocyte. The AAV capsid itself is broken down in the cellular cytosol, and then antigens are presented on the surface of MHC class I molecules, and if recognized, can trigger a cellular immune response and effectively clearance of the transduced hepatocytes. Thus far, this has not proved to be a safety concern in hemophilia clinical trials, but of course would limit efficacy. Right now, there's not a clear predictive biomarker, and so the way we monitor for this is looking at factor activity. Liver function studies, namely ALT, appears to correlate with this response. And then interferon gamma ELISpots to capsid positivity to capsid peptides, which of course is not something traditionally done in clinical labs. It is done on a research basis only. It's important to know that some, but not all trials have demonstrated that in the setting of a capsid immune response, this can be controlled by steroids, but in now a couple different trials, it's been demonstrated that not all AAV vectors, if this capsid immune response is triggered, are universally responsive to steroids. The salient point is this hypothesis is generated and supported by at least some clinical data, is that the actual composition of the vector cassette may influence the likelihood of developing this capsid immune response, and also whether or not it may be controlled by steroids. So there is a working hypothesis that increasing CpG content when unmethylated can trigger an innate immune response, triggering this capsid immune response, which may ultimately not be responsive to steroids. And this has been observed in at least 2 clinical trials in hemophilia. So what do we know about short-term safety of AAV? There actually is now quite a bit of data, and thus far there have been no major safety concerns that have come out of hemophilia clinical trial, and this is remarkable, particularly in the setting of there being a wide range of doses that have been employed for hemophilia gene therapy. There's a small number of patients that have experienced fever, arthralgias, myalgias within 24 hours post-vector. These have resolved without intervention and not posed major safety concerns. There is increasing data coming out of other systemic AAV clinical trials that probably have some application to the work we do in hemophilia. So first, there is now 1 approved systemic AAV vector for spinal muscular atrophy, which has really quite remarkable efficacy. This is a little girl, which, this is a disease that essentially is universally fatal or requires respiratory support early in being a toddler. And it's really quite remarkable what this little girl with SMA is running. So again, remarkable efficacy. But what was observed in the clinical trials that these patients could have really quite remarkable LFT elevations, and thus was approved with a box safety warning for acute liver injury. It's important to note, however, the doses being used here are quite a bit higher than what's used in hemophilia, up to 400-fold higher. But again, suggests the potential for liver toxicity. And then similarly, work coming out of muscular dystrophy trials, again, using doses higher than what we use in hemophilia, suggests was observed acute kidney toxicity and cytopenias with systemic AAV vector doses. And then lastly, the more recent events that have been observed using an AAV8 vector for X-linked myotubular myopathy. Now 3 subjects actually in the highest dose cohort of 3 × 10⁻⁴ vector genomes per kilogram unfortunately passed away in the setting of progressive liver failure. And increasing, we need additional information to really understand exactly what happened here. But collectively, data from clinical trials using systemic AAV vectors outside of hemophilia suggests that there are likely dose-limiting toxicities of systemic AAV vector infusion. Again, these are all observed using doses that are greater than or equal to 1 × 10⁻⁴ vector genomes per kilogram, so quite a bit higher than what's being used in hemophilia. The theoretical risks associated with AAV relate to the potential for genotoxicity. So we know from direct sequencing data that AAV, it has capacity for integration in a relatively small percentage of cells relative to the number of transduced cells, and this has been demonstrated in small and large animal models as well as in people after either vector infusion or environmental exposure to AAV. In animal studies, namely in neonatal mice studies, AAV integration has been linked with the development of hepatocellular carcinoma. And in subsequent really carefully done studies, the data suggests that AAV integration related to hepatocellular carcinoma risk is dependent on vector doses, so direct correlation with vector doses, the degree of underlying cellular division at the time of vector infusion, and that there appears to be an integration preference for sites of active transcription, and that the risk of development of hepatocellular carcinoma was increased with the use of non-hepatocyte-specific promoter, which again, all hemophilia trials are using hepatocyte-specific promoters. What do we know from in human experience? Again, data from the first patients to receive a systemic AAV vector. So this was hemophilia B patients. This is looking at their liver function studies. So their ALT and AST are in blue and red. And then their alpha-fetoprotein done as a measure for screening for hepatocellular carcinoma. And again, up to 15 years after follow-up, these men's livers looked healthy both by serological testing as well as by ultrasound evaluation. So the caveat, I think, with this data is that these men did not maintain sustained expression, and we didn't do any integration studies to formally document there was persistence of the viral vector in the transduced cells. I guess the other point about genotoxicity is there are data following systemic AAV vector. So this is a trial done in porphyria, again, using vector doses that are on par with what we use in hemophilia. And what they documented was random low-frequency integration events with no evidence of tumorigenesis, suggesting safety related to systemic AAV vector infusion. Okay, so what do we know about risk related to the transgene? So they're either factor VIII or factor IX transgene. The theoretical risk is that if you express either the factor VIII or factor IX protein, that you could develop an inhibitor. This has not thus far been demonstrated, but I think it's important to note that currently all trials are enrolling subjects that have a prior significant history of factor exposure and without a history of an inhibitor. So we're effectively a bit cherry picking subjects relative to the risk of inhibitor development. There are, importantly, preclinical studies that have demonstrated that hepatocyte expression of either factor VIII or factor IX, including factor IX podula, induces tolerance. So this actually conversely suggests that gene therapy actually may be effective at inducing tolerance. So overall, the general consensus is that risk of inhibitor development is likely quite low, and again, has not been observed in clinical trial. And then the other transgene-related protein risk is the potential for thrombosis. Nearly all hemophilia B trials have adapted the use of the factor IX podua transgene, which has about 8-fold greater specific activity relative to the wild-type protein. Thus far, there have been no immunological or prothrombotic concerns that have emerged from clinical trial. And what we know about the biochemistry of factor IX podua is that the protein appears to be similarly activated and inactivated relative to the wild-type protein. So overall, this would suggest that the thrombosis risk would be related to the actual levels of expression consistent with the wild-type protein and not necessarily inherent to factor IX podua itself. So relative to the transgene, we can start to define the therapeutic window of expression based on existing epidemiological data. So these data are far more defined for factor VIII than they are for factor IX. So we're effectively extrapolating a bit from the factor VIII data for factor IX. But I think if we wanted to define the therapeutic window, on the lower end, we want to have a factor expression that's minimally effective at preventing or eliminating spontaneous hemarthrosis. And then on the upper end of expression, we want to have expression that does not confer a prothrombotic risk. So this is a graph that's been shown, I guess, now many times, looking at a number of just epidemiological data, looking at number of joint bleeds relative to endogenous factor VIII activity. And as you might expect, as you have increasing factor VIII activity well into the mild range, so you have a reduction in joint bleeds. So somewhere on the order of in between roughly 10 and 15% of factor VIII activity confers annualized joint bleeds that are less than 1. Suggesting this may be a minimal level of targeted effective expression. And then the super therapeutic end, and now multiple epidemiological studies, it's been demonstrated that elevated factor VIII activity is an independent risk factor for venous thrombosis. So what this graph looks at is factor VIII activity relative to the odds ratio of venous thrombosis. So what this would suggest is that super therapeutic factor VIII expression that's sustained would not be desirable for concerns around prothrombotic risk related to elevated factor VIII levels. And then some of the outstanding questions, and this relates to what do we say is the targeted therapeutic expression, relates to discrepancies that have been observed and either one-stage traditional activity assays that are done most commonly in the United States, and then chromogenic assays that are done perhaps more commonly in Europe. But nonetheless, their discrepancy is important for defining our therapeutic window. So this has been observed both for factor IX Padua as well as for factor VIII discrepancies in these assays. The discrepancy between the one stage and the chromogenic assay for factor IX Padua is likely best explained by underlying biochemistry of the protein. But the difference in the one stage and the chromogenic assay for the B domain deleted version of factor VIII that's used in gene therapy is not clear. And importantly, this discrepancy and how it's observed in the context of gene therapy has not been observed in the nearly 2 decades of experience using essentially the exact same protein for recombinant protein administration. And these one-stage assays, the discrepancies between the one-stage and the chromogenic assay become important based on clinical trial data. Because depending on which assay you use, you start to potentially cross therapeutic thresholds. So this is data from one trial looking at factor VIII activity over time, looking at the factor VIII activity by the one-stage assay versus the chromogenic assay. And you can see if you use the one-stage assay, the levels are super therapeutic, or if you use the chromogenic assay, the levels are within therapeutic range. And then on the lower end of expression, if you look at one-stage factor activity over time, you can see these men are anywhere from roughly 5 to 20% levels of expression. And then, of course, if you use the chromogenic assay where the levels would be observed to be lower, you'd be crossing therapeutic thresholds into the mild and moderate range. So again, becomes important for defining the therapeutic window as well as providing guidance to patients on what their in vivo hemostatic function following gene therapy actually is. And so I think the answers for which one is most appropriate will come from phenotypic data coming out of a clinical trial and then enhanced biochemical understanding, ideally from the purified hepatocyte-derived protein. An additional outstanding question in the field relates to durability of expression. So if you have your transduced hepatocyte, there are theoretically multiple fates of this transduced hepatocyte, including cellular division, in which, in the best case scenario, only half of the daughter cells would maintain your episomal transgene. And then similarly, the hepatocyte could undergo cellular death, or your episomal transgene could undergo gene silencing, and all of this would result in effectively the same outcome, which would be transgene dilution or loss. So what do we have in terms of real world data to help guide what we might expect? So the first, from preclinical studies, we know from canine models that factor VIII and factor IX expression has been sustained for up to 10 years. And we know from clinical trial in hemophilia B, what's published is up to 3 years of long-term expression. And then in abstract presentation, we've had up to 8 years of sustained expression. And then in hemophilia A, the first successful hemophilia A trial observed an unexpected decline in expression between years 1 and 4. And then more recent presentation of data have demonstrated stable expression for up to 3 years following gene transfer, suggesting that hepatocyte-derived factor VIII following gene therapy can indeed be stable over time. So again, the question of durability remains unclear at this time. Despite what I've gone over in terms of risk related to AAV and the transgene and sort of outstanding questions, I think it's really important to keep in mind what we've seen. The overwhelming data that have come out of clinical trial are really quite positive. So again, no major safety concerns and really remarkable evidence of preliminary efficacy. And it's important to keep in mind, all of these potential risks and these outstanding questions. But the overall point is there's really quite considerable promise in hemophilia gene therapy. So I think that the lab monitoring following vector infusion is potentially variable depending on what the outcomes have come out of clinical trial with that particular vector. Namely, if what immunosuppression intervention has been undertaken, if any. So there's potentially a couple different outcomes. What medications were used for immunosuppression? Were they administered prophylactically or were they administered reactively? If immunosuppression was used, were patients responsive or not responsive to immunosuppressive medications? And then depending on what the medication is, there'll be required monitoring for side effects related to the immune modulating medications. The other component that's important for consideration of how you would monitor patients following vector is the durability profile of the individual vector and the risk of crossing clinically meaningful thresholds. Again, that may dictate the frequency of monitoring required long-term. And then lastly, the other consideration for sure is the logistics. So can some of this monitoring be done locally? Can you get patients into clinic, and at what frequency? Can you develop collaborations with or partner with visiting nurses or a local physician to help monitor the patients following gene transfer? So I think that the licensed product monitoring will likely be consistent with the monitoring that was done in clinical trial. I think at baseline, because the long-term safety concerns that have been outlined in preclinical study really relate to risk of long-term toxicity to the liver, would be to really have a good understanding of the baseline liver health of patients. So at baseline, patients should have good LFT evaluation, get a baseline alpha-fetoprotein. Again, this is for the theoretical risk related to genotoxicity that, again, has not thus far been demonstrated in clinical trial. And then an understanding of the patient's baseline liver health as it relates to potential for fibrosis and et cetera. In terms of the first 3 months post-monitoring, a lot of this monitoring relates to the potential for a capsid immune response. So the labs are typically quite frequent in the first 3 months following vector, approximately twice weekly. And again, the monitoring for capsid immune response thus far has been liver function studies, a factor assay, and interferon gamma ELISpot assay. The ELISpots are unlikely to be translatable outside of a research setting. So I suspect that we'll be monitoring liver function studies in a factor assay. And the graph here on the right just demonstrates what I would argue is the importance of frequent monitoring. So this is a factor IX patient. The graph here, the green line represents an increasing factor IX level. And you can see in a very short interval of time, the patient lost roughly half of his peak expression, essentially within about a 10-day interval. And so this again highlights the importance of frequent lab monitoring and intervening if immunomodulating medications are being given reactively very quickly. So again, you can see he had a decline in expression, steroids were initiated, and then subsequently his levels stabilized and remained stable off immunosuppression. And then outside of this capsid immune response, roughly 4 to 6 months post-vector, a general rule may be to consider doing LFT monitoring and factor assay monitoring approximately monthly. And then thereafter, I think the frequency of monitoring will depend quite a bit on the durability profile of the vector. So what I've said here is between 6 and 24 months is to consider a factor assay approximately every 3 to 4 months, again, to make sure that the patient's factor level is not crossing clinically meaningful thresholds that may guide your anticipatory guidance for the patient. And then I think the other point in terms of assessing liver health is, generally speaking, you may consider a yearly evaluation of the patient's underlying liver health, and that would be in the form of liver function studies and screening alpha-fetoprotein, and then consideration for either ultrasound or some kind of imaging of the liver to monitor health of the patient's liver. In summary, and some of the conclusions of what we've just outlined here, the goal that we're all working towards to create the ideal vector would be that the vector would safely achieve predictable and stable and durable factor expression that's able to effectively eliminate or markedly reduce bleeding using the lowest possible vector dose. And I think that those points are important to keep in mind when considering the ideal vector for a patient, that there's sort of multiple competing interests that ultimately play into what may be the right choice for the patient. And then, of course, when explaining and consenting the patient to receive vector, to outline what are currently outstanding questions, although hopefully in the future we'll have a better sense of the answers. So the first is, understanding the predictability, or in some cases particularly related to what we've observed so far in factor VIII, is the unpredictability of expression. And then, why are some trials able to observe durable expression and some are not? What is the time course of durability of expression? Defining acceptable upper and lower limits of therapeutic expression, determining that activity assay that best correlates with in vivo hemostasis, and then outlining potential risks related to the transgene-derived protein, which include inhibitor development, which thus far seems to be markedly low. And then again, having expression remain within a therapeutic window. I've talked quite a bit about durability and stability of expression. And then again, the long-term safety as they relate to theoretical risks around genotoxicity, which again, in clinical trial, there have been no major safety concerns, but these have been outlined as potential safety concerns in preclinical study. And then lastly, the persistence of multi-serotype cross-reactive AAV neutralizing antibodies that are likely to preclude repeat administration. And I think this has implications when you upfront pick the best vector and following the current progress in gene therapy with the hope of being able to overcome pre-existing neutralizing antibodies. So again, I think the guidance for patients has a lot to do with balancing outstanding questions while wanting to push forward with clinical development and in the setting of really quite remarkable progress and evidence of excellent safety and preliminary efficacy.